So good afternoon to the Israeli participants and good morning to our outstanding friend in the US, Professor Ken Mendel. I'm Daphne Morovitz from 8400, and it's really a great opportunity to welcome you all. We're going to have a fairly brief but very important kickoff for two-day strategic implementation, FHIR implementation session for the HMOs of Israel. And I'd like to start by welcoming Professor Nachman Ash, Director General of the Ministry of Health, to really share with us the ministry's vision, and from my own personal 8400 view, an amazing partnership and collaboration, which is completely not trivial, but is led by your leadership. So thank you very much, Professor Ash, and his microphone is yours.
Thank you very much. I'll be short. We want to use the time appropriately. So first, I welcome Mendel. Again, I don't know if you remember, but I was in your house in Boston when I was training.
I remember well.
20 years ago, yeah.
Wow.
It's so nice to see you.
Yeah, so it's very nice to see you, and thank you very much for joining us and sharing with us your vision and your experience. And it's one of the leaders of medical informatics in the US and in the world. Your view and experience is very important for us to learn. We are trying to lead here the use of standards, and with your experience in the US, we want to enlarge the use of standards in our system. This is one of the obstacles that שים על מיוט בבקשה. Thank you. So we are trying to introduce FHIR into the use of for our organizations in the healthcare, and I believe this is one of the things that can bring us to much better opportunities and abilities to share data, to share applications, and to use our data in a much better way. This is a tough mission for us, but I believe we will be able to do that with the experience that we can learn from you and with the people that are leading this in Israel. Looks like it froze.
No, we hear you very well.
Okay. So this kickoff experience here is very, very important for us to learn from, and I hope that we'll have a very useful time now, and then we'll continue and implement FHIR in our system. So again, thank you very much, and thank you all of us for being with us.
Thank you, Nachman. Thank you very much. And before turning to Ken, I'd like to introduce Ron Rednick, the Head of Regulation, Digital Health and Information Systems Directorate from the Ministry of Health. Thank you, Ron.
Hi, everybody. Good afternoon. Well, I'm very new. I'm actually the brand new Head of Directorate, and I think part of my responsibility is dealing with the HMOs and digital health. So I'm very happy that this very important initiative can combine two of the strongest aspects of the Israeli system And two aspects, we have to make sure we always be in the cutting edge of any new innovation, new technology, or new way of thinking that exists. And I think this project is a very important one, actually a strategic one, which we have to make sure will allow us to be at the front end of all other systems. I actually just came back from the OECD. I've been there for 3 years. And in the OECD, basically, they think there's very system praises regarding most aspects of the health system. I think the HMOs are they're definitely a vital part. I can actually say they are the most vital part of the very system. And making sure the HMOs will lead the way in adopting new ways of thinking, new way of transferring information, new ways of leading innovation is it's not important. It's crucial for us to make sure we'll always be able to provide the best value for our patient in the resource we have. So this project, I think, is the one all of you will take part, and us as the ministry will try to accommodate and allow to prosper as much as we can. It's a vital one for us, and we are confident that with your leadership and with our guidance and assistance, we can make sure we'll be one of the first systems which paved the way for using FHIR as I'm not saying full implementation, but it's a way for us to be able to provide a lot of value for our patients, for industry, and for our doctors too. So do make sure that we are going to allocate resources for that. But the most important resources we're going to allocate for that are you, the people from the HMOs, from the ministry, which will allow us to create this breakthrough. So I want to thank Professor Kenneth Mandel for this initiative and for allowing us to be part of this brand new way of thinking, which we are confident will be able to be one of the first countries to lead the way. Thank you.
Thank you, Ron. And before introducing Professor Mandel, and I'll do just a very brief introduction, because Ken, I hope that you will elaborate more. I do want to emphasize that this session today is so unique, because I don't think that in any place, other place in the world, there are 4 HMOs that cover a full country's population. And these 4 HMOs are now starting or have started in an implementation process of FHIR, and hopefully not only FHIR, but Balkan FHIR and research FHIR, in order to really extract the most valuable asset of clinical data, which is the clinical data out of the EMRs. And I think that what makes Israel a very unique country to implement FHIR in. So just really very brief introduction, and then Ken, the floor will be yours. Professor Ken Mandel directs the Computational Health Informatics Program at Boston Children's Hospital and is the Donald Lindbergh's Professor of Pediatric and Biomedical Informatics at the Harvard Business School. He's trained as pediatrics and a pediatrician and a pediatric emergency physician. His work at the intersection of population and individual health has had a unique sustainable influence on the development field of biomedical informatics. And by all means, thanks to Dr. Asher Reagan here, who is on the call with us from Yad Nadiv, and other leaders from the 8400 leadership program, we were introduced to Ken 3 years ago, just less than 3 years ago. And I think the Fhir-Il story starts there. And Ken, I'd love you to take the lead and show us the way. Continue showing us the way.
Fantastic. Yeah, I had a wonderful trip. Thank you for hosting me just before the pandemic. It was terrific to have gotten that in. Be harder now and meet everyone in person. Let me go to a slideshow here. So I'm happy to be interrupted during the talk. I'm happy to be interrupted during the talk or to answer questions at the end. All of that is fair game. The most important thing is that we get to share some thoughts and ideas this morning. So the question that you're asking really is the right one. How can we use some early lessons? And I do think the US is a good example. I'm going to try to highlight which aspects of what we did are the ones that I believe should be focused on for early success. So I think this is the right question. How can we make the system more intelligent, more automated, and have data flowing where it needs to be in a usable format? So I like to use this example, which is an example of real-time intelligence. In 2011, there was an earthquake in Virginia, not far from the capital, Washington, D.C. It put our Washington Monument into scaffolding from damage. And the east coast of the United States has a very hard crust, so you don't get much movement, but the shockwave goes a long way. And some data scientists, a couple days after the earthquake, put together this perimeter. And if you were outside this perimeter, you read about the shockwave on Twitter before you felt it. Now that's real-time information. And I don't think Twitter intended to have created an earthquake detector, but they did. And there's tremendous amount of information in these self-reported information from populations of individuals. They're not the only ones. There's a company here that's like Fitbit called Jawbone, and this is their sleep tracker. They provide a software as a service interpretation of your sleep patterns, and therefore they have the data from millions of people, and they were able to detect also an earthquake, everyone waking up in the middle of the night using their Jawbone detectors, sleep trackers. And, you know, before those two examples, I actually had seen a very interesting talk by Jeff Dean, who's the master AI guru at Google, one of the earliest employees. He developed their AdSense algorithms. And when I was visiting Google with the US Centers for Disease Control more than a decade ago, he showed this graph. It was his first public talk. Now he's quite public and well known, but he showed this search term stream for terms relating to earthquakes that he had put together. And here he too showed that Google had, again, with no seismographic equipment whatsoever, inadvertently built an earthquake detector with people getting up and searching. And I wondered why, when I saw this, why people were searching Google in the middle of an earthquake. You know, it's going to be a bookcase is going to fall on me. What should I do? But I then was in my office here in Boston, and my monitor on my desk started shaking. And I'm not a trained Californian who would have immediately run outdoors. So instead, I went to Google News to see if there really was an earthquake and if I really needed to bother myself to get up from my desk. Indeed, there was. And at that moment, I realized this is why Google's able to also track earthquakes. Tremendous amount of information in the streams of data we collect in the healthcare system that is mostly lost. Now, I say that with the utmost admiration for what Israel and the HMOs have done in providing learning health system and information to inform about vaccine safety and efficacy. In fact, it is world leading It is a decade ahead of where anyone thought anyone would be. And I offer my deepest congratulations. Also, I'm very pleased that one of my own faculty who's back and forth between here and Israel, a Harvard Medical School professor named Ben Rice, has been very intimately involved in publishing some of those New England Journal papers. So I say this not with hubris, but with admiration about what you have done, and think that it bodes very well for what you can do, even more so once you have interoperable data. So if I look at the United States and I think about what do we have in our electronic health record systems, I did a back of the envelope calculation and think that there are, and I polled a few of my pals, and this is by no means a authoritative estimate, but I think there's about 2 billion clinical notes produced by clinicians per year. And these notes are accessible. Information in them is accessible with natural language processing, computerized reading of text, and that's a largely untapped data source in healthcare. We have ICD codes, which are diagnostic codes, part of our billing system. We have data on medications, orders for medications and procedures and other things, laboratory tests, procedure codes. We have race and ethnicity. We're needing to improve our data there, and the US is working on that. And before too long, we're going to have a substantial amount of patient-generated data, and an abbreviation here in the United States called SDOH, which is Social Determinants of Health. There's a lot of emphasis on collecting those data about the patient's own surround in the social environment that may impact their ability to stay healthy. So how might we want to use this info, and how are we currently using this information? So if I look here at this beginning of the pandemic and our Centers for Disease Control and Prevention, what they were doing, I was really shocked to see that several months into the pandemic, in MMWR, which is the leading publication of the CDC, and it comes out as weekly report, decades old, highly venerated report of the latest CDC information. They were trying to figure out what the underlying health conditions were, who was at risk for bad outcomes from COVID, and they only had clinical data on 5.8% of the cases that they knew about. And I was like, this is a problem. And we began talking to the CDC at that moment in time. Now, a great writer in the US, Siddhartha Mukherjee, wrote in the New Yorker a very brilliant piece just the next month, where he wrote about what the coronavirus crisis reveals about American medicine. It's worth a read, and I'll read his quote. Think of the EHR as a kind of intranet, flexible, programmable, easy to use. Right now, its potential as a resource is blocked, not least by the owners of the proprietary software who maintain it as a closed system, and by complex rules and regulations designed to protect patient privacy. It should be a simple task to encrypt or remove a patient's identifying details while enlisting his or her medical information for the common good. Now, this wasn't the first infectious disease crisis where electronic health records and their limitations played a role. When there was an Ebola outbreak in Africa, an interesting thing happened. A gentleman walked into a Texas emergency department, the Texas Presbyterian Hospital, and the triage nurse in the emergency department said, where are you from? He said, Liberia. She clicked that into the record. And then she took his temperature. He had a fever. That went into the record. And then she sent him back to the waiting room. And even though those two data elements were in the record, there was no intelligent process in the record putting those two things together. Doctors don't jump to the travel history as the first thing they look at when someone comes into the emergency department with a fever. He ended up being discharged home with a diagnosis of an upper respiratory syndrome, infected a couple of nurses. He came back, died of Ebola. A couple of the nurses got Ebola. Wasn't great. The hospital briefly blamed the electronic medical record in the press. The electronic medical record company pushed back and said, that's not our responsibility. The hospital retracted its blame. And what happened next was an example of how we function that in a not very effective way. So the Centers for Disease Control gets on the phone with all the electronic health record vendors, and they say, how can you put together a decision support system so that Liberia and fever trigger an alert, a big warning, as opposed to nothing. And so all the electronic health record vendors tried to figure out how to do this, and they did it. They implemented something that would would cause that alert to happen. And then they had to get on the phone, the vendors had to get on the phone with all their customers, and it had to be implemented at each local site. So hundreds, thousands of hospitals had to do this. Stop what else they were doing. We were lucky, not one single other person walked into an emergency department with Ebola. So none of that work was ever used for anything, and it was one-off. And so what could we learn from this? Well, two things. One is, wouldn't it be nice if there were interoperable modular parts of this system so that we could push out new triage questions? A simple survey, right? It's a triage survey, something simple that could be pushed out that changes with changing conditions. And the second thing to think about here is the geography of this patient's travel history is just one example of a risk factor. And it's just one example of how geography is important in someone's health. Geography could tell the emergency physician how likely this patient is to have been exposed to chlamydia or tuberculosis, or to live in a food desert and have nutritional challenges, or to live in an area with a lot of gun violence, and direct care. Wouldn't it be nice if the CDC, for example, or the WHO or other health organizations could expose their geographically related risk data across an interface that lets us pull it into decision algorithms, as opposed to building a one-off Liberia fever detection system that's kludged together. So, you know, we're at an interesting moment where our researchers in Israel, in the United States, are expert in artificial intelligence, machine learning. We can predict the future. These are some pieces that we've published. And again, this is actually with Ben Rice, who's back and forth between Israel and here. And up in the upper left, in the British Medical Journal, 10 years ago, before almost anyone was talking about machine learning and artificial intelligence in healthcare in a realistic way, he published a paper that showed us that we can predict the future. We can know who is going to come into the emergency department up to 2 years in advance with an episode of domestic violence. And this was based on learning patterns of prior diagnoses related to visits. And more recently, a very interesting paper showing that we can actually know who's going to have a suicide attempt or a suicidal gesture. well in advance. And as you know, there are epidemics of suicidal attempts, and I can tell you even deaths among adolescents in the United States right now. Knowing the future is something we can do, but the question is, how do we build those algorithms into our health systems if we don't have modular ways to introduce algorithms into care? So there's something that you may have heard of in the United States. It's part of a law, the Health Insurance Portability and Accountability Act. There's a right for patients to get a copy of their data, and this was established in 1996, which by now it's unfortunately a very long time ago. And still, it's been hard for patients to get a copy of their data because there's so little will to get it done, even though it's been possible since then to give patients electronic copies of their data. So there's another idea, and this is really related to the learning health system. There's a term that I'm sure everyone on the call knows in some language or another called evidence-based medicine. And then the pun on this is medicine-based evidence, which is to say that instead of looking at the clinical trials to figure out how a patient has done or what we should prescribe for this patient, we look at the experience of other patients. And the experience of other patients is captured in a few different ways, but by far the most robust way is right now in electronic medical records. That may change in balance over time as we get more patient-generated data into our workflows. So the problem is that electronic health records were generally not designed for any of these purposes. They're not designed very well for getting data in and out. And another thing is that data are most useful when they're combined across sites of care. And I think that's what's so exciting about having all these different organizations on the Zoom today and in this meeting that you're hosting. And that integrating software or bringing external data sources to the point of care is exceedingly difficult. Data are stored in EHRs differently everywhere. I've learned that's true in Israel, as it has been true here. And that's why some standardization effort can really go a very long way. Whoops. So in the United States, our initial foray into this world of interoperability started at during the recession, when Obama was first coming into office. His health policy team was able to grab $48 billion in 2009 and to invest that in essentially paying doctors to buy electronic medical record systems. So they were paid about $44,000 a doc if they had an electronic medical record system that they could implement. And hospitals were paid more. So it might not sound like that much money. And in fact, if you're a regular doc, it might have really paid to not do it because it slowed you down to have one of these electronic health records. But if you're a practice of 50 docs, all of a sudden that kind of is a lot of money. It went from about a 5% adoption rate of electronic medical records in inpatient and outpatient settings to a 95% adoption rate of electronic medical records. And if you look at what these things cost, Partners Healthcare, now it's called Mass General Brigham. That's the Mass General Hospital and the Brigham and Women's Hospital, which are joined together in a corporate structure. They spent about $2 billion to purchase Epic. And that includes consulting money, consulting dollars for firms to help you implement Epic, because it's not an easy thing to implement. And so we do back of the envelope calculations. This is non-authoritative, but I think more than $500 billion US spent on commercial software and the adoption of that software. And remember, our electronic health record software comes empty. You have to fill it yourself with data. So that's why these things are very, very expensive to implement, and over prolonged periods of time. So this is a piece I wrote with Griffin Weber in JAMA that just shows you all the different types of data, some of the different types of data that you might use to characterize patients. Could be at the point of care, it could be in a research database, whether that's data from pharmacies, data from supermarkets, data from patient reports, data from patient-controlled health records, from genomics companies like 23andMe, from your gym memberships. All kinds of things will tell us more and more about you as we try to characterize you. None of this stuff can get to the point of care in the electronic medical record very well. Here's an example of something we did at Boston Children's. This is a Pharmacogenomics Initiative. And if a patient was being prescribed something called 6-mercaptopurine, 6-MP, which is used in inflammatory conditions as well as cancer, it turns out that there's a pharmacogenomic variant that means you metabolize that drug differently. It's good to check that in advance. And for this dialog box to come up upon prescribing took 6 months of work in the electronic medical record for one dialog box. This is not a good way to move into the genomic medicine era. So this here we see, you may recognize Watson and Crick shortly after the discovery of the double helix structure of DNA. Would they have been surprised that sequencing the genome is something I can do trivially? I can have someone spit into a tube, and for about $200 or $400, I can get back their entire genomic sequence. But to actually look in the electronic medical record, despite this $500 billion investment, if I want to produce a list of all the patients who have asthma at Boston Children's Hospital, that actually requires a computational project at the level of at least a postdoc, because the diagnosis of asthma simply recorded in the electronic medical record may mean that the patient had asthma in the past but doesn't have it now. It may mean they were ruled out for asthma. It may be an error in the coding. And so there's computational ways to get that much more precise, but really odd that we're further behind on that kind of even simple phenotyping, like what disease does the patient have, than sequencing the entire genome. So, and I'll mention as an aside, not really the topic for today, but we're collaborating, and we're going to bring FHIR into this collaborative. We now have 9 children's hospitals using interoperable technologies to share genomic data plus electronic health record data, so we can do this high throughput phenotyping across millions and millions of patients. The 2.8 million is just the patients at Boston Children's in the database. We don't have 2.8 million patients currently. That's a 10-year slice, but we're now increasing numbers of patients getting sequenced, and think of all the discoveries that we can have if we can put the genotype and the phenotype together. So when I saw that the Obama administration was going to invest $48 billion in electronic medical record adoption, mostly $36 billion of that to pay physicians, mostly to buy the record systems, I wrote a piece in the New England Journal that said, let's think about electronic health records more like the iPhone. And the iPhone was 1 year old, and the iPhone was supporting a third-party apps system. And the third-party apps were able to connect to the iPhone through an API, an application programming interface. And so that meant that if you had a cool astronomy app that let you track the International Space Station, which appeared right away in the App Store, was one of the really exciting early iPhone apps. you didn't need to fly to Cupertino, California, have a meeting with Steve Jobs and the Apple team. You had an API, a software development toolkit, and this was starting to really be interesting. So when we wrote this piece at the very end of 2008, just after Obama was elected, there were 10,000 apps for the iPhone. When it was published just 3 months later in early 2009, there were 50,000 apps for the iPhone. And 1 year later, when we started our project on healthcare APIs, more code had been written for the Apple iOS apps ecosystem than any other software project in history. So we caught this phenomenon on its rise up, and it's a very interesting opportunity. And what we argued is that using this API method would get you 3 things. 1, because the apps are separable from the EHR and developed separately, and because they're substitutable, you can substitute one for the other in this model, just like on the iPhone. A clinician who is a rheumatologist may have a different view into the record than a obstetrician, than an oncologist, and they all need different data. And the obstetrician needs data on two individuals, the mother and the fetus, for example, and these things aren't that well supported. These kind of variations not that well supported. Also, and Israel is startup nation. This is the way for innovators to be able to get to the point of care without dying on the vine waiting for an integration. This is plug and play is the way for, let's say, an AI-oriented startup in diagnostic imaging to connect to the record system trivially. Also, this allows those innovators, the companies that are getting to the health system, to compete with each other, which should drive down prices for the health system and for patients. So that's the idea. Now, we ended up parlaying that 3-page paper into a $15 million grant, even though from a policy perspective, we were not very much attention was paid to us from a research perspective. They gave us what we needed, and they gave us 4 years to develop the technology and to have it independently, sustainably supported and adopted. So we said we were going to do it. Did we believe we could do that all in 4 years? Not necessarily, but we gave it our best shot. And what we said was, we took this $15 million and we asked only one question. Now, this took a lot of self-control because people wanted us to spend the money on solving all kinds of other problems too, like patient identifiers or moving information around between health systems, health information exchange, et cetera. We asked just one question: can electronic health records behave like iPhones or Androids, in that innovators readily create and widely distribute substitutable apps across thousands of installs, so that an app can be written once but run anywhere in the healthcare system? So we were inspired by Tim Berners-Lee. Now, Tim Berners-Lee, many people on this call will know, invented the World Wide Web. Now, it's interesting, when I talk to students now, I mean, all of a sudden we cross some threshold. The informatics students and fellows now do not know who Tim Berners-Lee is. So history is, you got to repeat history. So Tim Berners-Lee created the web to solve a very specific problem. He wanted to share preprints of his articles in physics, and he therefore needed the articles to look nice, marked up. They need to have titles and columns and figures. That's HTML. He needed to be able to move those HTML pages around, HTTP, and to give them, let you find them. He needed to be able to render them so that they look the same anywhere. That's the web browser. And he needed to be able to serve them up, the web server. And he did one thing that made this more than just a little preprint project. He standardized these features in the World Wide Web Consortium so that the HTML page would render in a browser anywhere, in any W3C compliant browser. So that turned out to enable tremendous innovation without his having to do all the innovation himself. So he did not invent Netflix or Google Maps, but he enabled them to happen with parsimonious interoperability. So I just want to pause and emphasize here that parsimonious objectives in the interoperability journey are, in my opinion, key to success, especially at the beginning. And I'm going to give you examples of how we did manage to focus on a parsimonious set of goals, which took a long time to achieve nonetheless. So at the beginning of our project, we were inspired by an article in Wired magazine, which is a tech magazine that's been around for decades and decades by now. And the editor of Wired, Tom Getz, had commissioned a few graphic designers to reimagine what a laboratory information system of the future could look like. This was the picture from Wired of a piece of paper with daisy wheel printer output on it, showing a patient their cardiac risk. This is very common. Now we have portals that are the same thing, but on a screen. And these designers created things that looked like this. And this is a picture of what an interactive cardiac risk app could look like, showing how your risk changes based on your smoking status, weight, your cholesterol, CRP. So fortunately, it was released under a Creative Commons license, so we're able to reuse this image. I want to emphasize that this thing in Wired magazine is just a Photoshop image. It's a watercolor painting. It took our developer 1 week to turn this into a real app with a pixel for pixel rendering of that picture, but pulling CRP, ESR, smoking status, et cetera, across our candidate application programming interface. So all of a sudden, we had this app substitutable. We had 3 open source electronic health record systems that we were able to adapt by putting the API on top. And so we have an app that is now R. The R in SMART is reusable. It's reusable across the 3, and it's substitutable. We could add it or delete it without modification. We held a contest that was promoted by the White House, and that contest led to a winner who was using our API. It was one of the first health app contests ever, if not the first. And for a $5,000 prize only, we got 15 apps developed. The winner was this very nice small company called Polyglot that had created patient-facing, user-friendly medication instructions in 22 languages. So they had this huge resource, and they were able to turn it into a smart app, pulling the medication list across our API in 48 hours. In 48 hours, they took a product that they created knowing nothing about SMART and turned it into a smart app. At home at Boston Children's Hospital, we went to our CIO and we said, what can we do with this whole grant? Can we do something here? And they said, yeah, we've been on the queue with our electronic health record company for 3 years, waiting for a rendering of blood pressure in kids adjusted by age, adjusted by percentile. Now, this, for those of you who are not in pediatrics, blood pressure norms vary wildly by age. This is a 2-day-old, a 2-week-old, a 2-month-old, a 2-year-old, a 12-year-old, a 20-year-old. They all have different norms. And once we went off of paper and didn't have the paper nomograms for the doctors to just fill in with their ballpoint pen or their pencil in the chart, they had no way, the cardiologists had no way to track easily this phenomenon. They didn't want to plot all the points again when they saw the patient, right? So this took 6 weeks for a programmer to develop a fully robust app. It took 9 months to kind of cram it into our electronic medical record system, but paying attention to security and networking and various other things. But all of a sudden we have this app running. So in patient context, when you pull up that patient record, this app, you click a button, it opens. It's not actually served up out of the electronic health record, served up off of our servers. It was used hundreds of times per week right away with no real promotion of it at the hospital even. Just there, clicked, used, and then the cardiologist wrote this up, improved care, and improved outcomes. I didn't think it would, but even just being able to visualize the data improved the outcomes and blood pressure management of these kids. Right away in our project, in a collaboration with 23andMe, here, compare this to the pharmacogenomic issue that we had before. Here we have 23andMe data, electronic health record data, and algorithmic risk map interpretation, all rendered in a smart app connected to an electronic medical record. This was implemented for real at Vanderbilt University in their cancer program, in their precision medicine program. We have an app gallery, which we've just released a new refreshed version of. And this is where we have listings of apps, and it's all up on our smarthealthit.org site. The nice thing about this gallery that's unique compared to other app galleries, even the Apple App Store, which is the grandfather of app galleries, is that there's a sandbox underneath and you can try the app. We have synthetic data in there, so you can actually try the apps. And the sandbox itself has been used by us and all the largest tech companies in the world in their development of FHIR technologies, and it's there for the using as well. So now I emphasized parsimony, and I want to show you how that parsimony played out to be successful in the United States, successful to date. And I'll also give you the caveats on what that success means. So here's a regulation. The regulation says that you need to, if you really want to get paid fully by our Medicare and Medicaid services, you need to have an API that gives a patient access to their own health data. So this goes back to that 1996 HIPAA thing that never was operationalized for patients. It was popular because this is it's just hard to argue against a policy that's giving patients their data. So this policy didn't begin with make competing health systems share their data with each other. That wasn't the policy. The policy was give a copy of the data to the patient. Hard to argue against. Everyone's for it. Patients are for it. Now, the regulation was 2016, and even then, it was too soon, the regulators felt, to either mention that FHIR should be the standard data model, or that SMART on FHIR, our API, should be the standard API. They just said an API. So now a big scramble had to happen. And there were several companies that had created proprietary versions of our API. We continued to give it away for free. And we continued to give it away not only for free, but in ways that are substantially at risk in terms of the project, meaning the following. We used an Apache license to let this stuff out. So that means that someone could take just a piece of what we did and use that combined with proprietary technology. And in fact, some electronic health record companies had done that. It also meant that they could relabel it as their own. They didn't have to call it smart or credit us or do anything. So we took our ego, our brand, and everything out of what was required. And the amazing thing is everyone still refers to it as Smart on Fire. They love to use our logo, all that stuff, without being required to. So it turned out that lack of grabbiness, that specific technology that worked well and had been shown to work well, that was also free, that was commercially favorable to anyone starting a business, they weren't going to be tied down in some way, was attractive. So we convened a group. Now this is also important. This group was essential. And in fact, I gave Daphne the coordinates of the leader of the current leader of this group. This is a consensus group of electronic health record companies, our standards organization, HL7, which is an international standard, that is the HL7 ingested the FHIR project around 2013 or maybe it might have been 2011 when they started, and somewhere in there. So when we started our SMART project, there was no FHIR. So the FHIR project started, and after 2 years of that, it became clear to us that we should use the FHIR data models with SMART. That's how it became Smart on Fire. This group got together in response to the regulation, which had teeth, okay? So the EHR companies had to provide this certified technology, or they wouldn't be providing certified technology, and then providers couldn't use their technology to satisfy regulations so that they could get paid. So it had real teeth, and these guys got together and they picked the open, free, and elegant solution. And within a year, all the electronic health records companies had, or the big ones, had implemented Smart on Fire in their systems. Now, so 1 year goes by, now Smart on Fire is there in Epic and all the other systems, and Cerner and other systems, and Apple comes along and says, we're going to use this. Now, Apple had pulled into its company a couple people out of our community, hired them away. And at first we thought that was going to kill the project, potentially, because they were taking our engineers, but it turned out to be actually quite beneficial to the project, because those guys inside the company kept the flame alive, and they convinced Apple to connect to initially 200, now 800 health systems through an open standard. Now, Apple was not an open standards oriented company. Even though iOS kind of feels a bit like an open standard because it's so widely used, it most certainly is not. And nonetheless, they connected the Apple Health app to now 800 health systems, giving, as of today, 200 million American patients the ability to download their health record onto their iPhone in FHIR format. Not only to download it, but to make those data available in the core to other apps. So other apps can use the FHIR data that you pulled in from your hospital or HMO into your phone. Those apps are highly curated by Apple now, so that we don't have a bunch of bad acting apps. And here's our logo. We were very happy to see up on the Apple stage at their very famous Worldwide Developers Conference. Now, there's CMS, our Medicare folks, Medicare and Medicaid, our insurance, our federal insurance, our federal payer, started also to provision payer data to patients through something called the Blue Button, and a project called Common Health, which is a not-for-profit trust, got together and got grant funding and created an Android analog to the Apple Health app, so that people using Google phones, Google Android operating system driven phones, to be able to also get their data. And now Apple is allowing interesting moves back into the health systems. Here's data coming back into the electronic medical record from a patient's phone. So the doctor is now actually seeing the patient-generated data in the electronic medical record. Okay, this is all accomplished. This is smart on FHIR into the phone for the patient to get the health system data, and it's smart on FHIR out of the phone to get the data from the patient's phone back into the electronic medical record. Parsimonious standards with initially some very interesting results. Okay, here's something that goes beyond that initial regulation from 2016. Also, around 2016, I don't do very much lobbying, but I got one sentence into an act called the 21st Century Cures Act, which says that basically all electronic health records have to have an application programming interface that provides access to all elements of a patient's electronic health record. And here's the key, that some legislative aid or senator put in without special effort. This, I didn't understand. When I first read it, I'm like, well, what does that mean? And then I realized I could argue, and I did, and it worked, that without special effort had to mean that it had to be interoperable, because otherwise it would be a different interface everywhere. There has to be just one interface for this to be without special effort. There can't be a different interface for every different brand. So you need to have one interface. And when the next administration came along, I knew the regulator very well from work we had done together at the NIH, Don Rucker, and we, at first he said, we don't need any more regulations because he's a free market, libertarian, oriented politically. And I said, Don, we do need regulation because we don't have a free market now. This project is about developing a free market for innovation. That free market's not there. And he went from saying we don't need regulation to writing a 1,400-page regulation, implementing to a large part this one sentence that was finalized last year. Sorry. So we now have two regulated APIs, and this is a long process. I told you this began at the beginning of the Obama administration. The rule from that law went into effect 1 year ago and takes effect fully next year, okay? And that rule tells us that this Smart on FHIR API specifically needs to be supported in all health information technology by the end of next year. And it also tells us that another API, which I'm about to tell you about briefly, called the Smart HL7 Bulk FHIR Access API, also has to be supported. Now that one came in very late. We had in 2018, the same regulator, Don Rucker, said to us, can you create a population level analog to this Smart on FHIR API? It's all very nice, that we can connect apps for one patient at a time, but we need to move population data around. We need data on payment. We need to be able to assess care. And for much, much, much less than that $15 million grant, much less, we started a project where we designed a population analog that also would allow a process or an application to authorize itself to the electronic medical record, but now to get out whole population data, again, in the very same FHIR format. While the Smart on FHIR project took 10 years, this project, 3 months in, or somewhere between 3 and 6 months into the project in 2018, Medicare was already using our just candidate API that we were published on GitHub to provision data to healthcare organizations. And they have 2 APIs, one for ACOs, which are more like these accountable care organizations, more HMO-like in philosophy, and one for traditional fee-for-service provider organizations, providing all the data on payment, et cetera, on these populations. Now, here's another piece of what we've been, of what this all means. So this should be both encouraging, but also tell you where parsimony means you have to decide just how parsimonious you're going to be. So the data that have to be released under these regulations is called the US Core Data Interoperability. And that is a very specific data set. And it doesn't have everything in it. It does have notes. So notes will be available on your iPhone, your Android phone, through the native health app or any other app. And all these data elements have to be available also in the population level extracts. So can we use this legislation called the 21st Century Cures Act to actually create a 21st century health IT system and a real world information economy? I think we can. And I'll tell you, we are still pushing, and it can be door-to-door combat to make sure that each aspect of the way these things are implemented in electronic medical records actually fulfill the goals of what the data liquidity is about, and not just a simple regulatory requirement. So one thing that we're very motivated to do is to be sure that the electronic health records can be as robust and functional as they would like to be. And I hope they become, I hope they excel in their functionality and in what they provide back to doctors and patients. But it's also possible to remove data from electronic health records, subject it while leaving those electronic health record systems absolutely in place, and to subject it to modern architectures and public health data science. These are examples of companies that are making sidecars where you can pull the data out into a FHIR server and potentially do transactions, even apps and things, on that FHIR server. There are other companies that are smaller and less well-known brand names that are doing this also. And I think it's a potentially very interesting area. It's a potential area for Israeli innovation as well, either in collaboration with these big companies or with separate technologies, or some combination. So this is just an example of a population health app that we designed to start to show you what an organization could do with completely standardized data in terms of looking at, for example, patient reported data along with immunization data. Now, here's the interesting thing, right? Sure, most organizations can produce a dashboard or a chart from their health record. What's the difference here? The difference here is that this dashboard will work anywhere because the data coming out of the bulk FHIR API are standardized. So the thing here is scale. We should be able to do this and do it absolutely anywhere. So there are ways to go. So we actually designed an app that takes our first app that we developed, this FHIR API enabled, Smart on FHIR API enabled cardiac risk app. And now we're also looking at population level data in the very same paradigm. And something very much like this with our collaboration was implemented already in a major health system to look at, to manage populations. So when you look back, and when I talk about parsimony, here's Tim Berners-Lee again, you know, with just a couple of things, 2 APIs, we're starting to be able to see that there are, that these are building blocks to create all kinds of innovation. And you want to be very thoughtful about what you try to achieve initially. I just want to give one call out to a project that comes out of our team led by Josh Mandel early on in the pandemic. Actually, before the pandemic, he had begun to take a World Wide Web Consortium standard for a verifiable health credential. And he's now a health lead at Microsoft, but still spends 20% of his time with us on the SMART team. And he designed a FHIR-driven health credential called a Smart Health Card. This project went from conception early in the pandemic to wide-scale deployment. We now have an authorized healthcare credential that is that's being used in vaccine passport, like the green, it's called the green card, the green pass, that gives privacy-preserving health credentials to individuals. It can show up in your wallet on your phone and is already used across the state of California. It's used across the state of New York. It's used across the state of Washington up in the Northwest, and Epic and Cerner have implemented as well. I think this will be used internationally as well. There's a lot of evidence that it is. It's an open, free standard, and it shows you that some things we learned about how to first innovate, then deploy and test, then start to scale, and then standardize later. This is still, I think, making its way through a standardization process, but it's already used almost universally. We're getting better at doing these cycles faster. It's very important to think through the issues of privacy, confidentiality, of protecting patients. These apps, patients give their data to apps. How well do the apps behave? I won't go into the whole regulatory side here, but we don't have it perfectly worked out yet to manage how those apps behave. How do we, if we start to move more population level data sets around, how do we be sure that they're used in the best interests of the patient populations from where they come? I have a graphic that we updated recently looking into the future that shows that this journey, it takes a village to make this happen. It took many parts of our ecosystem, our Medicare, contributions by our VA. We had bipartisan support in Congress, something we don't hear about very much anymore. We had amazing continuity in keeping eyes on the prize across 3 presidential administrations and the folks working at the deep levels. This is our team at Boston Children's Hospital, and we're very eager to keep in touch and to collaborate. I'm sorry I went a little bit long, but I would like to.
It's perfect. That's just right. Thank you so much, Ken. And I'd like to leave some time for Q&A. And Roy, I'd like you to lead the Q&A session. Thank you. Thank you so much, Ken.
My pleasure.
Yeah, okay, great.
Roy, you're mute. Mute.
Okay, can you hear me?
Now we hear you well, thanks.
Yeah, thank you. So yeah, Ken, thank you so much for this great talk. The way I've been kind of digesting what you're saying is this, you know, there for a lot of us here, it's what you're describing is a kind of if we're going on this road together, we're seeing things that we'll be able to see as we go into this road, and some of them are probably closer than we imagine, and some of the applications and you've shown might be farther than we hope for us. But I think we have a really great and dedicated team here, and this is not really the first step. We've been doing this for a while together, and we're really excited about this. And maybe, you know, for some people here, I think on this call, it might be the first time that they hear from you. And I was wondering if you had just any advice for people who are really early in this FHIR journey. They're all leaders of their organization, as you are in yours, but if you had any advice for people from you know, who have a maybe business, technical, or medical background, and are kind of assigned with this task to deliver this kind of FHIR adaptation, to be innovators in their own organization, what would you say to them?
Yeah, well, I would say that, you know, I think I would encourage you in this meeting today to think about what a logical starting point is, so that you don't do unnecessary work, but that you do work that drives the ecosystem forward. Your challenge is slightly different than ours in that we had, for better or for worse, we had dominant vendor products in place that were the target of influence of these regulations. And those vendors had to, EHR vendors had to produce the FHIR mappings. So you have more of a constellation of different products and perhaps less standardized, less dominance by a single vendor. So you have to, in that ecosystem, figure out how can you get started by doing something. Now, early results are always encouraging and are very good marketing. So, and the 80-20 rule is what we followed all the time. We did not choose to map all the data in the electronic health record. We decided to map some of the data in the electronic health record, the key data. So what I would suggest that you guys think about in your 2-day meeting is a very achievable set of data to commonly map across the different HMOs on the Zoom, and to think about some standardized infrastructure that supports FHIR in which to host those data, and to make some population level inferences and to demonstrate something, or to recreate a dashboard. You know, is there anything besides COVID to think about right now? You can decide that. It could be a COVID thing, it could be something else, right? But I would encourage an early innovation project. Maybe you want to look at the incidence of genetic disease. Maybe you want to look. Maybe you want to look at how how influenza season goes this year. Maybe you want to look at surgical rates. So I would think about something now. So that's a sort of health system facing population level approach. And the second thing to think about is, do you want to try to provision data to patients? That's another potentially popular strategy. And this is something where you could work with, I know Apple's not as dominant there, but there is this Common Health Project, for example, or you could create your own app where patients are able to get some amount of their data back. So things where there's like visible progress right away. And again, I would keep things as parsimonious and simple as possible at the beginning.
I see your mic is not working, so I see you, Val. Do you have a question? Do you wanna jump in?
So I think Asher wanted to ask, and I think Ronen referred to in the chat before. So Asher first, and then Ronen. Asher?
Need to unmute yourself. Oh, maybe.
Still quiet.
Wait, sorry, I think we have a unmute.
Okay. Okay. Yeah. No, I
okay, great.
I
Thanks.
managed it. Yes. Thank you. Hi, Ken. Great to see you again. And thank you for the talk. I wonder if you could say a little bit about how FHIR can also be used not only for clinical purposes, but also for research purposes, either through bulk on FHIR or through third-party apps that researchers can use, and how one can communicate to the research community the potential of FHIR.
Yes. So I would say, in the same two ways. So one is population level data for understanding the characteristics of your populations. For example, the understanding the phenotype in gene-driven studies, or to monitor incidence of disease, to look at how patient populations can be characterized and subtyped, in a precision medicine paradigm. It's the same data that we all use in research now in clinically oriented electronic health record driven research, but ultimately it will be easier to obtain and it will come out in a standardized format rather than needing later to be remapped into a standardized format.
Have there been, just a quick follow-up there, have there been any examples, or is there potential, do you think, for researchers to use the integration into mobile apps and iPhone data to create research cohorts of their own, sort of disintermediating between the patient and the health system?
Absolutely. So there are already examples in the Apple Health Store, for example. There's something that they created many years ago called Research Kit, where you can actually do distributed trials that are completely patient engaged, and it becomes fairly easy to spin those up. So it is a very good use case. So you can give patients access to their data, or you can give them access to their data. There's another interesting thing that patients can do with their data once they have access to it, and that is to become the leaders of a patient-mediated health information exchange. So in the United States, we have a lot of trouble sharing data across sites of care, but if you give it to the patient, they can bring it to their doctor. And not just bring it and show it on their phone, but actually electronically give it to the doctor at another hospital. Or looking at it from a purely patient-centric perspective, they're getting data in from multiple healthcare providers on their phone in one place, something that no other function in the United States does universally. And this is something that we can do in that direction as well.
I'm going to continue asking questions from now on. So I see a question from Eyal from Khalid. I'm sorry, I can't unmute everyone, but the question pertains to where's FHIR going with relations to the OMOP standard? I know some organizations here already gotten started with OMOP, and can you just explain a little bit about what is the axis and what are the?
I think that's an evolving situation. OMOP has been a very successful project in terms of developing a wide variety of tools that can be used once data are in an OMOP format, and those tools are in global use. Now, the question that we're just going to have to wait and see is whether once FHIR in the United States is available universally, coming out of electronic health records under the regulation 1 year from now, a little over a year from now, do organizations, researchers, tech companies, do they want to remap the FHIR data into OMOP to use that robust ecosystem of analytic tools? Or do they want to create an ecosystem that uses the native of similar tools that uses the native FHIR format because it's already in that format? And so I get the feeling it will be a hybrid at the beginning. And I don't yet have a prediction of which way it goes. But the FHIR models are not as efficient to compute on because of their structure, but computing is getting cheaper and storage is cheaper.
יש פה הרבה אופציות, בוא נתאם, תראי. תמר גם בה?
So it's hard to know, but I wouldn't either. I would hedge my bets and look at both alternatives.
Great. Well, then, Obama, do you want to unmute yourself and ask your question that you had earlier? You're the first one.
Yeah, sure. So I'm Ronen. I'm an architect with the Ministry of Health and part of the Israeli core team. You mentioned before the social determinants of health in the context of FHIR, but so I was wondering if you can elaborate a little bit on where do you see the future in it? Because I mean, if you look at the research right now, they attribute 50+% of the quality of life and quality and longevity to SDH, but the FHIR and Smart on FHIR right now is much more focused on clinical aspects. So how do you see it evolve, and where does the SDH come into play?
So I'll point you to something called what I referred to before, the U.S. Core Data for Interoperability, USCDI. It's a pretty unique acronym, so it's easy to Google. And there's a version 2. And in version 2, they're beginning to require more about the social determinants of health and also more about sort of clinical care teams, things that are beginning to be practical in these ways. So it, of course, has to all go back to data collection. Are we collecting these data in a reliable way? But there's an emphasis here on beginning to do that. If you're not already collecting those data, it's not as low-hanging fruit, because now you have to change what people are doing at the front lines, as opposed to just on the back ends of these systems. So it might not be the place to begin, but it is a good place to focus on the questions of, we're going to have interoperable systems, we're going to have data exports that are very useful for research, for public health, for patient-driven care. What do we need to do to collect the data that we need? But I would consider that a slightly longer term vision.
I think we have time for one last question. Dr. Yuval Bar-Cohen from Schneider, do you want to ask it? Or I can read it if you're able to.
Sure. Yeah. Hi, Ken.
Hello, Yuval. Did you see your paper up there? Your paper was up. I didn't realize you were on.
Yeah, I saw, and thanks for the talk. I mean, I thought that I wouldn't learn anything new about FHIR, and you made so much sense in like order and putting everything in context. It was very fascinating.
Great.
So thank you very much. I think my question was kind of more earlier during the talk, and I think that you maybe prefer not to go into this topic because it's quite deep, but what about the regulations of the apps themselves? Because you talked about the regulations of the API and how to make providers provide the API. Yeah.
So let me tell you where we are with that. So our regulator who gave us this rule that requires Smart on FHIR and FHIR and bulk FHIR is not the same regulator that does healthcare privacy and management of healthcare information from that perspective. So when the data are in the electronic health record inside a health system in the United States, they're covered under the provisions of HIPAA, which I referred to earlier. And that's pretty well defined. It's not actually a bulletproof set of regulations. Those data move all over the place through all kinds of commercial opportunities, and they get de-identified and sent all around under HIPAA. Nonetheless, they are regulated under HIPAA, and we understand what that regulation means. When the patient takes their health app and asks then to, when the patient takes their health app and then asks to have the data downloaded into their, onto their phone, the moment it goes across the API, it's now regulated by a different agency in the United States called the Federal Trade Commission, the FTC. And the Federal Trade Commission can enforce things like terms of use and privacy policies that are there, but there is no universal standard for those terms of use and those privacy policies. And so the end user license agreement is what the Federal Trade Commission can enforce. And so there are efforts now to begin to standardize those and to make it also transparent to the consumer what the app is going to do with their data in a way that it won't technically enforce that the app only does that with the data, but will give the FTC the ability to provide enforcement if there are violations. And so that is a very complicated and interesting area, and we're going to have to see sort of how that plays out.